Good afternoon, dear committee and audience. I would like to present to you my 3-month progress of my PhD thesis investigating the cardiac complications associated with acute pancreatitis. My name is Veronika Lillik. I'm a second-year internal medicine resident doctor at the Hospital of Székesfehérvár, and my vision is to decrease the mortality of acute pancreatitis by foregoing the preventable complications. My mission is to conduct a high-quality research to understand the effect of AP on the cardiac status. I have 3 specific goals. The first is investigating the association between cardiac complications and acute pancreatitis. My second and third project is a protocol development for understanding the dynamics of cardiac functions during and after acute pancreatitis. My first project will be done by the methodology of systematic review and meta-analysis. Acute pancreatitis is a systemic inflammatory disorder with rising incidence and high mortality in the severe form. Organ failure is one of the most important predictors of severity and mortality in this disease, and heart failure is a common cause of death in this acute pancreatitis patient group. That's why there's a need to cover the association of cardiac-related abnormalities and acute pancreatitis. In previous cohort studies, it has been shown that the severe form of AP is associated with certain cardiac changes like ECG, cardiac indicator, echocardiographic changes, cardiovascular failure, and myocardial dysfunction. Therefore, our aim is to cover the importance of cardiac changes in acute pancreatitis. Our first clinical question is, what cardiac-related abnormalities are associated with worse outcomes in acute pancreatitis? The population is patients with acute pancreatitis. The factor is cardiac-related abnormalities, and the outcome parameters are hospital and post-discharge mortality, severity of acute pancreatitis, and length of hospital stay. Our hypothesis is that there are specific cardiac-related abnormalities associated with higher mortality and severity in AP. The clinical implication could be that cardiology screening in patients with acute pancreatitis is needed to early detect the cardiac complications and signs to prevent the cardiac complications. The second clinical question is, what is the association between the severity of acute pancreatitis and the cardiac-related abnormalities with the same population and the factor for the severity of acute pancreatitis? And here, in this framework, the outcome parameters are the cardiac-related abnormalities. We conducted a systematic search in 3 databases on the 5th of November with this search key, which contains the domain for acute pancreatitis and the domain for cardiac-related abnormalities. Our systematic search yielded around 20,000 articles. We are done with the duplicate removal and the title and abstract selection, and we have 1,500 articles left. We are currently doing the full text selection. My second project is a protocol development for understanding the dynamics of cardiac functions during acute pancreatitis. As I mentioned in the beginning, there are certain cardiac-related changes associated with the severe form of acute pancreatitis, but we don't know the direction between these 2 entities. There is no guideline about the cardiology screening in AP patients. That's why our aim is to cover and identify the cardiac-related changes and the risk factors for cardiac failure in AP patients. We want to design a prospective observational clinical study, if possible multicentric, for the following clinical questions. The clinical implication could be that cardiology screening in patients with AP is needed to detect the abnormalities and prevent the cardiac complications. The first question is, what are the incidences of cardiac-related changes during the acute pancreatitis course? The second question is, which cardiac-related abnormalities are associated with the severity and mortality of acute pancreatitis? In this framework, the factor is the certain cardiac changes, and our hypothesis is that there are specific cardiac-related abnormalities associated with the higher mortality and severity in acute pancreatitis. The third question is about the time dependency of these changes. We hypothesize that there is a specific time dependency pattern of cardiac-related changes. My third project is a protocol development following the previous study, because the post-discharge mortality in AP is under-investigated. The mortality during the first 90-day period after discharge is almost the same as during hospital stay. And 22.5% of this post-discharge death is caused by cardiac failure. The post-discharge management is unclear, especially regarding cardiology screening. There are no guidelines in the literature whether we should do a cardiology screening after discharge. That's why our aim is to identify the cardiac-related changes and the risk factors for cardiac failure after acute pancreatitis discharge. We would like to conduct a prospective observational follow-up clinical study, if possible multicentric, for the following questions. We would like to know what are the cardiac-related changes after acute pancreatitis, because we think there are certain changes after the discharge too. The second clinical question is about which in-hospital cardiac-related changes are associated with worse post-discharge outcomes in AP, where the patients are the same population. The factors are certain cardiac changes in the hospital, and the outcome parameters are post-discharge overall and cardiac-related mortality and post-discharge cardiac failure hospitalization, because we hypothesize that there are specific in-hospital cardiac-related abnormalities associated with higher post-discharge mortality and cardiac failure rate after acute pancreatitis. The clinical implication could be that post-discharge patient management regarding cardiology screening in patients after acute pancreatitis is needed to prevent the serious cardiac complications after discharge. Here you can see the summary of my ongoing projects with the planned submission dates. And I would like to wrap up my presentation with a quote from Albert Einstein: "Life is like riding a bicycle. To keep your balance, you must keep moving." Thank you for your attention.
Thank you for your wonderful presentation. I have a question concerning the second project. You mentioned that there are these planned investigated parameters. Can you give us some examples? I'm really interested in it. Thank you.
Yes, thank you. We would we are planning on the investigated parameters. For example, in the literature regarding ECG changes, the QT prolongation is the most investigated one. And we would like to do some laboratory markers like CKMB, troponin, NT-proBNP, and also we would like to assess the echocardiological signs, most importantly the ejection fraction, and if possible the global longitudinal strain. Thank you.
So first, congratulations.
Thank you.
I'm just wondering if are you planning to involve a cardiologist in your third project?
Most definitely. We are planning to do a big meeting with them. We already had a preliminary meeting with one cardiologist who suggested these parameters that I just listed, and we are planning to do a bigger meeting with more cardiologists from more centers, so we can include them in the study too. Thank you.
How do you plan to define the severity of pancreatitis? Do you plan to use some scores or only by clinical signs?
Most of the articles report on based on which severity score they assessed their patients. The most common one is the Atlanta criteria, which is the most common and recent one. But some studies gave other risk scores too, but we will collect them in the data extraction sheet to assess whether they use the same severity scores or not, because that's really important. Thank you for the question.
So if I may, I love your topic very much. It's great. I got so many questions. First of all, the laboratory markers, all of them are actually influenced by creatinine and kidney function.
Yes.
So how actually reliable they will be at all in assessing your outcomes. Also, the population, in your first project, you want to exclude pre-existing diseases.
Yes.
But actually, how can you be sure if the patients were screened or anything? Because this could be just precipitating factor of the decompensation they will
yes,
achieve.
You are absolutely right. This will be the biggest limitation of our study, that we don't know if those patients had any cardiology screening before the first admission to a hospital with acute pancreatitis. We won't know that. Some articles report that they excluded severe cardiac patients, because sometimes you just know if someone has a pacemaker, you just know. So these basic big cardiac complications are excluded in most of the studies that are eligible for our meta-analysis. So this will be a limitation, because we won't know the previous cardiac status of the AP patients. In the protocol, we would like to include every patient because we think that the change in the level of cardiac complications or abnormalities is important. But in the meta, we can't do that.